Well, let's go ahead and get this party started. Hello, everyone. I'd like to open the Central Oregon Health Council meeting for November. If anybody saw October, please let me know how it was, where it went. I feel like yes, so here we are. So welcome everyone. We can start with a round of introductions. So Kelly, would you mind kicking us off? We'll go around the room and we'll get to the video.
Hi everyone, Kelly Adams, Central Oregon Health Council.
Hey everyone, Carmen Madrid, Executive Director for Central Oregon.
Tammy Bainey, Chair and Tour Guide today.
Linda Johnson, Vice Chair, Community Representative.
Dan Stevens with Pacific Source.
Board of Field Consumer Representative and Levi Country.
I'm Derek Schutz County Commissioner.
Scientist for Education Service District.
Megan Hayes from State Community.
Counselor, do you want to go next?
Oh, yes, I am Counselor Courtney Casino. I'm also marketing communications there for local community there.
Kathy DeBone, and I'm here for the Newberry Regional Partnerships.
Dustin Zimmerman, Oregon Health Authority.
Lori Hill, CEO, Central Oregon Pediatric Services.
Heather Fenner, Deschutes County Public Health Director. Erin Moore, Deschutes County Public Health, and I'm presenting on the community care project today.
Trisha Wilder, I use she, her pronouns, and I'm represented first.
I'm Churchill Dennis with President Melbourne.
Beth Hatcher with the Crescent Community Center in Crescent.
Good to see you.
Your neighbors?
Yep.
Echo Murray, North Public County, I guess.
Wonderful. Good to see you again.
Yes, please.
Shall we go to online? And it's a little, well, I see Mr. Trelevin. Rick, do you want to introduce yourself?
Sure. My name's Rick Trelevin. I'm from Best Care Treatment Services. I'm the behavioral health person on the board. And my apologies, I was just submitting a grant through Oregon Buys. If any of you have done that, it's a pill, better than the feds, but not Amazon. So anyways, my apologies for not being there in person.
All right, let's kick it to Emily. Uh-oh, unmute. Okay, we can't hear you, Emily. Try it again.
How about?
Good. Oh, okay.
Sorry about that. Emily Solomon, St. Charles board member. Like Rick, I'm sorry I can't be there with you all in person today, and look forward to a great meeting.
Excellent. Thank you. Dr. Davis, Jeff, do you want to introduce yourself?
Hello, Jeff Davis with Pacific Source, Medicaid Medical Director in Central Oregon.
Excellent. I'm having a little difficulty. Let's see. I see Erin at the bottom there, and then Kelly, if maybe you could help. That'd be great. Yeah.
Hi everyone, Erin Fair-Taylor, Pacific Source.
Next, we'll do Ann Kilty.
Hi everyone, Ann Kilty, Deschutes County Public Health.
Thank you, Anne. It's a little fuzzy for me on this angle, so my apologies.
Lindsay.
Hi everyone, Lindsay Atagi, I use she, her pronouns, Pacific Source.
And Kristen.
Hello, Kristen Tobias. I use she, her pronouns, and I'm also with Pacific Source.
Did we miss anyone? Camille. Oh, Camille. Oh, most important, keep it. Make sure that everything runs smoothly. Are you kidding? Oh my gosh. That's Camille. Oh my gosh. Okay.
With Central Oregon Health Council.
Love it. All right. So next we have announcements. Any announcements that folks would like to bring forward? Okay, Dustin, please.
Hi everyone, Dustin again. Updates from my day, just quick. We did Governor Kotek appointed Dr. Sahil Athi to lead the Oregon Health Authority as director. So she will start January 16th, pending Senate approval. And then Dave Baden will serve in a deputy director role to this council. Just letting you know that. So one less position. So
Still holding on to
right.
Yes. Full bench of folks. Awesome. Anything else? Okay, Trisha.
Yeah, I'm pleased to announce that Leslie Neugebauer was recently named Vice President of Community Health, Social Needs, and Health Equity. We're calling it Community Health Pacific Source for short. As you know, she previously had served as the CEO director for Central Oregon, had been promoted to the senior director, so all of the CCOs, directors reported to Leslie in that role. Pacific Source is seeking to fill that role, but that explains why we won't see Leslie in this space. She will still be part of this work as she works really closely with health-related social needs is one of her primary objectives under her new role. So we will still see her intermittently in this space as she helps communicate the upcoming changes in the 1115 waiver, but not in a month-to-month process.
Got it. Yeah, well, bittersweet, and congratulations to Leslie, and how wise Pacific Source.
Right?
Yes.
She will still be doing work and leading work that certainly informs our work. And Rick, don't worry, she still says you're the best boss she's ever had.
Love it. Okay, any other announcements? I have a couple. I wanted to give a shout out to our friends at Jefferson County for being nationally recognized for the public health accreditation. That is a big deal. And so years went into that work, and wanted to just recognize that really puts them at a level, and especially for a smaller community like Jefferson County, the investment of not only the political will to lean into that, but also the work that it took to actually do all the things that were required for accreditation, the persistence, and just the overall passion for doing what's right for your community. I wanted to give a shout out to Jefferson County and a congratulations. And then the other thing I wanted to do is on behalf of the board, and I'll give this to Carmen, but it's to celebrate the great work of the Central Oregon Health Council team and all of the outreach that they've been doing to communities around the regional health improvement plan and the regional health assessment, gathering information. This last year, as you know, it was refreshed and far more inclusive and far more sort of the outreach, I guess, would just say it launched like a rocket. And so on behalf of the board, wanted to recognize that great work and the commitment that went into making all that happen. And so it's an opportunity for all of you to get together at Deschutes Brewery to either giggle amongst yourselves, to enjoy trivia night, or just have a meal and celebrate your great work. So on behalf of the board, just wanted to say thank you to all of you. I'm super proud to work with you, and I'm super proud of all of the outreach and commitment that you put into that. So
Thank you. Thank you
Yeah.
for the support. And really, it's the team that's making all of this happen. And we giggle all the time.
Oh,
actually,
good.
but
Yay.
I get to go to Deschutes Brewery.
yes, okay.
Yes, to giggle out.
Oh, good. Yeah, absolutely. Good giggling. Okay, so with that, if there are no other updates, we would move on to the consent agenda. Anything for to be removed or any edits to that? If not, I would welcome a motion.
Still moved.
Thank you. And that's thank you, Paul. All right, any further? That's great. Any further discussion? Okay, seeing none, all those in favor? Anyone opposed? All right, motion carries. So next, I'd like to turn it over to Councilor Ignazio and Mr. Bell. Great to see you both.
Turn the lights a little more so you can see the preview.
Yeah, we're having good lighting. You think that'll work?
We can try it. We won't put you in the dark. Do this like Emily.
Yes.
Conserve energy.
Kimmy, thank you for having us. It's good to see some familiar faces, and on behalf of Newberry Regional Partnership and the City of LaPine, we welcome to our community. So I just want to talk a little bit about a community-led effort that's going on here in LaPine, the Newberry Regional Partnership. Go ahead. So who are we? We're a team of public and private citizens that have come together to develop a long-range plan for growth in South Deschutes County and Northern Klamath. Part of our zip code is in Northern Klamath County. The City of LaPine is a service center for that area, so we have included that area. The goal of the project is to create a collaborative organization of community leaders from the public and private sectors to engage the broader LaPine community in planning for and dealing with changes associated with growth and change in the years ahead. LaPine is growing. How many of you know what's been happening around here? A lot of homes have been built in the last few years. The population has increased. There's new businesses coming to town. And there's a lot of concern from the community about these things. Not only the growth, but the change it's gonna bring. Go ahead. These are some of our partners. You'll see COIC is a wonderful partner for us. I want to say thank you for that. They've been doing a great job keeping us in line and focused. St. Charles is a partner, LaPine Community Health Center, the City of LaPine, the Community Development Department at the county, both chambers, Sun River and LaPine, the American Legion, Habitat for Humanity, a couple of banks in town, and so on. So some of our strategies for addressing growth and change were to conduct a community survey, and we did that in June and July. I'll give you some numbers here pretty soon on that. But afterwards, after looking at that survey, we decided to create a community civic engagement series. Hi, Jeff. He's one of the catalysts for this project, by the way. Thank you. So the community civic engagement series, the partners decided that we would do 9 sessions in 7 weeks. And so we have done 7 sessions now in 6 weeks. We've got 2 next week. It's been quite the undertaking, and they've been really successful. Then we'll do focus groups. We'll explore creating a 501c3. But the big bonus at the end of all this is to create a community strategic action plan. One that doesn't sit on the shelf, but one that involves all of those partners and community members to address growth and change. So we did the survey and we used a consulting group that helped us with that. They did the original one in 2006 before we became incorporated. So it's very nice to have them back. The study population was these zip codes. 16,800 people. We had almost 1,200 participants, and we needed 571, so we were very pleased with that. So, out of the survey, these were the big concerns from the community. So, growth and change, public safety, the threat of wildfire, followed by homelessness, drug use, and crime, the quality of public education, access to local health care and 24/7 emergency care, lack of local retail opportunities, basically is what that was, recreational opportunities and family-friendly activities. And there was a lot of concern about social divisions in the community. I think organically, this project has helped to lessen that by giving people an opportunity to voice their concerns. So in the civic engagement series, I hope you all grabbed one of those papers. We can pass these around. We engage in community discussion. We encourage candid conversations and bring forth issues, problems, challenges, successes. We take notes on that and post it for the public and get it to the people who need to see it. We based our series on the dimensions of community vitality. So everything from the survey went into education, health and human services, public safety, economy, natural resources, and arts and culture. That's how we kind of organized almost 3,000 comments. And as I said, we're almost done with this series. Next week is the end, and we're addressing education. And right now we're working on the focus groups. So we've got 4 focus groups. We're about 25% complete with that. Habitat for Humanity has been very generous in helping us pay for these things. And if you want to learn more, you can visit this website. COIC is hosting the page for us. All the notes, the schedule, the background, and the survey is on that page. So, thank you.
This has been really incredible, I think, giving voice to the greater La Pine area. Because so often, you know, we solicit the voice of those that are within the city limits, but there's such a greater population that live, work, and play here. And they needed to have a voice as well, especially as we're growing. And so, you know, that's feeding into the growth of our healthcare resources. And the project that I'm going to talk about today is actually, it began before the Newberry Regional Partnership survey, but it's been helpful to hear from the community and kind of validate what we're doing, that we forecasted this growth, we could see that the need was here, and began this work years ago. So it's incredible, and I was able to moderate the health session that we had and hear from the community. And you know, I think we're kind of in this growing pain season right now where we feel the need for emergency care in La Pine, having an emergency room, but we're not quite there. We're just not big enough. It's not financially feasible for anyone. And so it was great to have St. Charles in the room with us, have our emergency response services in the room, have Deschutes County Mental Health, as well as us from La Pine Community Health Center, to really talk through those things with the community and explain why we can't have an emergency room here, but what we can do for this growth. And part of that is increasing access to primary care and other services to help keep people healthy and hopefully keep them from needing those emergency services as much as possible. So, as I said, I'm from the Pine Community Health Center. We have been a federally qualified health center since 2009. Go ahead and go to the next slide. We are quality leaders. We're in the top 10% across the nation. We just received our 2023 award, and also for advancing health information technology for quality. And so we're very proud of that. We serve all ages and all stages of life in the South Deschutes County, Northern Lake County, and Northern Klamath County areas. We have 2 locations here in La Pine. One is a school-based health center, one is our main site, and then we have a school-based health center in Gilchrist. And we serve currently approximately 7,000 patients. That number is on the rise because we have added new providers to our panel that are accepting patients. And we have about 85 employees now, the number of which is also growing currently. We're busting at the seams. We provide primary care. We have a walk-in clinic, still primary care level of service, RN point of care, mental behavioral health, health education and nutrition services, outreach resources, and our school-based health centers. Move on to the next slide. And we are currently building a wellness center. So this is so stinking exciting. I've been working on this for a few years with our previous CEO, Charlotte DeHate, and our new CEO, Aaron Trapp. This wellness center is an expansion of our current campus. So while we weren't able to connect the 2 buildings, it's still on the property right behind us. So we're just growing our campus. It's located at the corner of First Street and Bluewood here in La Pine, just right off 97. And it'll be 3 floors. I think we're only the 2nd building in La Pine to be 3 stories. So we're really excited about being a high rise. 3 floors, yeah, 27,000 square feet. You can move on to the next. And these are the services and expansions that are coming because of this. So we're adding a dental clinic as part of La Pine Community Health Center. And one of the questions I get asked out in the community is, do we really need another dental clinic? We have 3 in La Pine, but we do. We have gaps in who's able to receive that care here. Part of those gaps are our Medicare patients. Some of those Medicare patients cannot receive their services here because there's just not the programs to help them afford, because the basic Medicare plans aren't covering that dental service. The other gap is those who may not be able to qualify for the Oregon Health Plan, but they still cannot afford their own insurance. And so as a federally qualified health center, we'll be able to provide a discounted fee schedule and make sure that they're able to get their preventative care and extractions and fillings and all the other full service dental care at a price they can afford, or possibly not for any cost at all. And that's the beauty of us being an FQHC, much like Mosaic. We're built the same, and it's a great way to be able to serve our community and not turn anyone away. So we're very excited, and we already have a dental director. So it happened almost by accident. Some might say fate, but we have a dental director who's working on our dental policies and programs. And when the doors open to this building, we will be ready to accept patients, and they will not have to be a patient of LaPine Community Health Center to receive dental care. They'll stand alone as far as that goes. There will be expansion of mental health, and we are working on an agreement with a partner here, and we will have news about that soon, but I can't reveal who that is just yet, but they will take the majority of our second floor for expanded mental health services, which is super important. And that was actually a hot topic at the Newberry Regional meeting on health as well. So a lot of concern around that. An imaging center, first for LaPine. So we have x-ray at St. Charles, and we have x-ray at LaPine Community Health Center. What we don't have is mammograms or ultrasounds or CT scans. And so everyone has to go to Bend. And we're very excited. This will also be part of LaPine Community Health Center services. And it will be accessible for anyone. They will not have to be orders from our physicians. They will be able to use it for St. Charles for their care. If they have a provider in Bend that's ordering a CT scan, they can come here as well. So it will truly be accessible to everyone in our service area. Primary care. So our primary care capacity is expanding by 45% as a result of this expansion. So by adding this building, moving our admin offices to the new building as well, we'll be able to add 4 more providers to our current panel. So that equals about 4,600 patients that we'll be able to bring on. And with the growth of LaPine and the number of houses going up, we're gonna need it. So very excited. We also will be able to offer childcare for our staff and offer community education space so that we can do more classes and teach our folks how to live healthy lives, how to exercise, how to cook, healthy meals, etc. And the childcare is going to really boost us around recruitment and retention. So pretty exciting. We can go on to the next. I won't read all this to you, but of course, what all of that means is that we are going to have greater access to care that's close to home. We're going to have a healthier community, hopefully keep them out of the hospital as much as possible. And, you know, there's going to be earlier detection of illness. I mean, the mammograms alone is going to help us to have earlier detection of breast cancer. And that's, you know, going to save lives. So pretty awesome. Go on to the next one. And so just a little update on where we are with the cost. The full project includes a new building plus remodel of current. This is just the new building on its own. So we have secured funding of, check my colors here, just over 5 million. We have a capital campaign that's in progress of about 5 million. And then also we have kind of a gap that we're working on for financing or additional grant funding. You can go on to the next. This is our $5 million campaign progress. We're around 32% completed on our campaign, and we hope to be at 50% here around January or February. And we have some applications in progress for funding, and just moving right along. We've had contributions from the state of Oregon. We recently, you might have read in the news, we received a $1.6 million gift from Yield Giving, which is Mackenzie Scott. That came as a surprise, and we were just super elated. Of course, HRSA, First Interstate Bank has contributed $25,000, and we have some pending applications with Murdoch Trust and Sun River Rotary Club. We've also had a lot of support from the Deschutes County Commissioners. Representative Reschke has been incredible, just really going to bat for us to get some of this funding. The community support that is behind us has also just been wonderful. And so we're very excited. We keep moving on. And we can go one more slide. All right, so are there any questions about the project? Input? Well, thank you for letting me, oh, Patty.
Okay, when is gonna be open?
Yes, that's, but it did say coming 2024 instead of soon, but you know, our builders are like, maybe don't say that just yet. So they just broke ground and we just have dirt moving. So it's likely gonna be December of 2024 or like January 2025, but we're making some good progress. I heard yesterday that we're ahead. So pretty excited. All right, well, thank you.
I just wanted to take a moment and say that I think both presentations are a reflection of a really rich community with a lot of passion and commitment to bringing one another together. As we all probably would know, that the smaller the community, sometimes the harder to bring people together, especially in challenging political times, financial times. You know, we have some things on the horizon right now that make it difficult to bring community together. And on behalf of COIC, being able to work with Kathy and it really is a model of getting it done, of going to community and asking for their insights instead of telling the community what their needs might be. And I just think it's incredible to see what's been happening. And for the Lapine community, I mean, for the health center, to think from 2009 to where you are today, and the level of care that is able to be provided in this community, in the newest city in the state of Oregon, which in that time we've also had a city actually decided they don't want to be a city anymore. Bringing this level of care to your community is going to do exactly what you said, which is save lives. And so thank you so much for the journey that you're on and for being those voices for your community to really get it done. So, yeah, great job. And thanks for making time to be with us today. So, yeah. Okay, any other comments or questions? Okay, moving right along, let's go to the next part of our agenda, which is the Finance Committee update. Megan.
So we had our finance committee since the last meeting, and at that committee, we had some asks from the board regarding our financial audit. And so we were able to meet as a committee with the auditors and address some of the questions. And then we did some work with Justice Committee and the auditors related to naming the vacancies between the health council finances and the CCN finances. And that all came together, and then the auditors emailed that all of the questions were answered and it was satisfied. And so the board did vote to the audit come to the board for approval.
Wonderful.
You.
And thank you for that extra pop in there. I know that there were, you know, it was close, but I think that commitment that we're making sure that it's final and there isn't anything else in the opportunity to ask questions. I suspect for the finance committee, that was a little extra time invested. So thank you for that.
Well, we always appreciate questions too. So I think that's our role as a governing board, is to ask those good questions. So we want to welcome them when they come and you know, look through the questions and we come back to the board. So it's good. And the auditors are great and stimulating the things like that. And it's a lot for them too with the first year. So I mean, fresh eyes. So I think that was a good process.
And a shout out to Carmen and the time and commitment that you and the team put in to make sure that they have the accurate information and
Everything, which was
great, yeah.
great exercises, and they actually put forth some, you know, best practice recommendation.
Wonderful, good. Well, that's a commitment of your time too, so thank you very much. Okay, so is that a motion? Do you want to?
Sure, I will make the motion.
Okay. I will second. Excellent. Further discussion?
I wondered if we could just have a copy of the recommendations for the board, as we start planning out our activities, features and stuff. So great to have something you can go by. Yes.
Oh, yeah.
The recommendations you referred to.
Yeah, we could provide that with the e-book.
Yeah, I think so. Good, you can.
Later, and maybe just as written annual.
Are you seeking policies and procedures for the
I
audit?
think it's the practice commission.
Okay.
The maybe recommendation. And I think just outline those and just put everyone's packet.
Great.
And last month you had mentioned that some of those improvements and recommendations were already underway, so that's really great too. Great, thank you.
This is based on what we saw in our packet. Is that correct? That I. So.
Yeah.
Looking here.
Yeah.
And this confirming that we're doing.
No.
Great. You know,
Any other discussion or comments? Emily?
Hi, yeah, thanks. And my apologies, if this was what you were discussing and I didn't, fully catch it on audio, but the items that were brought up last month around the, funds that exceeded FDIC, limits has been addressed sufficiently. I think I'm seeing you shake your head. Yes, Tammy. So that's been resolved.
Yes, I should have been more clear in my statement. So last month, Carmen had mentioned that she had put into place those sweep accounts to be able to make sure that we were meeting that sort of best practice. I almost wanted to call it a
Perfect.
yeah, so thank you for raising that. Yes.
Great. And then I guess too, just to follow up there were some questions also about breaking out some of the categories around the grants a bit more. Did that happen offline and that we're all good on that? And will the board receive any of those further breakdowns or should I just connect offline with Carmen or Trisha about that?
Do you recall that piece from last month?
Yes, they
Okay.
were, those were some of the recommendations. They were not broken out in previous audits.
Okay,
And so that was one of their recommendations to break it out for a little bit more clarity.
great.
And I can also include in the next packet on written reports, just a copy of the final audit.
That would be great. Yeah, and if we complement that with the list of the best practices and recommendations, I think it's going to hit on a number of these pieces.
Great. Perfect. Thanks so much.
that's the piece where Justin and the auditors walk through the CCO side and the COHC side to make sure everything mapped.
It's
Great.
working.
Thanks, Megan.
Sorry, there was a person at the door. I think it's locked. We don't want to chase her in the parking lot, but someone is trying to. Thank you. Okay, so any other questions? And thank you for that, Emily. All right, all those in favor? Anyone opposed? All right, motion carries. Thank you, Megan, and thank you to the finance committee as well. All right.
The investment update.
So the next item, so I actually did not, but there's an ask from the board that we looked at having some investment support in the organization, and that's what the finance committee. So it's not at the finance committee, but it's a part of Rick chairing the group about should there be a subcommittee, should it live with the finance committee? They landed on the investment review and finance committee at this point, and then they asked that Carmen would assess some different options of who can support us in looking at investment work with the central regional authority. And then she will bring that to the finance committee. So there's not a recommendation from the subcommittee at this time.
That's great. Any questions or comments on that? Thank you for that.
And then what do you want to just, this isn't on the agenda, but a quick preview that we do have our budget season coming, the CCO budget. And we know the cycle happens every year. And one of the uniquenesses of this is that we do a budget approval with the Central Oregon Health Council for the CCO budget, and Civic Source does an approval of that budget as well. So we try and marry up the timeline as much as possible. Trisha did email out that we will be doing a budget overview at the November meeting and using the whole 90 minutes with Justin's video, and then it will come to the board for approval. That's what I think that's maybe for the December meeting.
And as we might recall, last year was a little bit bumpy in terms of sort of understanding the process, the timing, the role clarity, etc. So there's a small group, I think it's executive committee, that's going to talk about how we prep this year to make sure that the board is provided ahead of time the information that helps to sort of reconcile what we talked about last year, how that plays into this year, and making sure that we feel a bit more prepared for that conversation. Great questions were raised. I think it just felt in real time a little bit like we maybe couldn't answer the questions, not to anyone's fault. It just started to sort of take some a life of its own, and we needed to kind of remember what our role is and why we have the role that we have and why we have two budgets. So, more to come there, and anyway, I think that's scheduled.
And anyone is welcome to come to the finance committee as well, because that's kind of where the working session happens, and you can dive into the details, ask the good questions, and then that work can come to the board for approval. So I think that's the other part of the process. If there's interest, come to the finance committee. We can really work through those questions.
Thanks, Megan. I would just underscore that because finance is on the 29th, is that right? Of November? COHC finance?
Yes.
And that would be the opportunity to do that, because Pacific Sources Board meets on December 12th and approves our budget, our enterprise budget, which includes all of our CCOs, which includes this CCO, right? So this feeds that, which goes to our board 2 days prior to us in this room approving the Central Oregon the Central Oregon CCO budget, right? So that's always been the thing that's been a little, for people who aren't aware of those timelines, it feels a little bit out of step. It feels like it usually gets resolved with, oh, I just had some questions about these assumptions. And so we've been able to resolve it before, but I think just thinking proactively about the sequence of those meetings in your own heads around what questions you might have, then the next time this body meets, it will have gone to finance for recommendation. It will then have gone to our Pacific Source board. And I can't remember a time in my history when the board didn't approve our budget as presented, because we go through committees and multiple steps and multiple bounces. So by the time it goes to our board, it's ready for approval. And 2 days later, it will come here. So just to underscore that with dates. So Megan's invitation to come to the finance committee meeting or reach out, as you can always do, to anybody on the Pacific Source team if you want some clarity on budget assumptions or key budget drivers for 24. The biggest thing that's gonna really be probably will overshadow any other assumption is what is the impact of redetermination, right? That is going to overshadow any other kind of assumption, as every budget has multiple assumptions. That's going to be the biggest, right? How many members are impacted? What is the risk profile of the members who do not redetermine versus those who do? What impact does that have on the ultimate financial performance in 2024? And I think we make pretty good educated guesses about that, but they are educated guesses because we are forecasting what ultimately will happen with redetermination and then the financial impact of it. So yeah, it'll be an interesting budget year, as we always say, but with a capital I this year.
So our finance committee is on the 27th of November at 2 p.m.
27.
And we're happy to send out invitations to the board for this round.
That would be great.
It's a good idea.
And Megan, it might be helpful also in that meeting to capture the questions that get asked. And that way we can maybe answer those to the board as well ahead of time. So that, you know, these were the questions that were raised. I suspect there would be some alignment of maybe the same questions getting asked. And then instead of, well, that was brought up, or we're sort of hitting it ahead of time of in the packet, we can have that material. These are the, you know, in case you're sort of the frequently asked questions sort of overview.
And we have a list of some of those questions that got raised last year, because I'm sure they could be raised again.
Sure.
The last thing I would say is it would probably be, and I can help with this, or anybody from finance could, is to be good to reach out to any health council members that aren't here today, thinking about this process as we're talking about it, that will then potentially come in December and go, huh?
Yeah.
So that would probably be something worth doing. And Pacific Source is happy to pull anybody in a room and just have a side conversation. I know Justin, among others, will have good questions about the budget because he loves to look at numbers and we love that. So
Great.
perfect.
Anything else? Anyone online? Okay. Megan, thank you. And thank you for the commitment there too. That's investment of time. Okay, so next let's go to the regional assessment update. And we have a PowerPoint in your packet. Yes.
So normally, Miguel and team will probably be presenting this because of all the amazing work they've done. But they are actually in Madras getting set up for our sixth community survey session. We've done this in 2 weeks, back to back. And, but I wanted to just do a refresh on where everything is on the regional health assessment, as well as the timeline for the regional health improvement plan. Because all of these pieces are spaces to get the accreditation happening. We use the MAP framework, which is a technique of mobilizing for action through planning and partnerships. Next slide, please. We'll start here. So what is a regional health assessment? So it's really a snapshot and a picture of our community's health. And a lot of this is designated for our region, not just a county, but our entire region, to not only accredit our public health partners, but in conjunction with the work we're doing with them, but also it creates our RIP, our Regional Health Improvement Plan. And our last Regional Health Improvement Plan was from 2020, when the pandemic started, through the end of 2024. And so that's a 5-year cycle of our Regional Health Improvement Plan. And what it is it's a snapshot of health indicators outside the region and all of the social determinants of health in terms of how we come together in our health in our community. Next slide. So the Regional Health Assessment vision was that we were going to add another component here so that there was a lot more community-driven aspects to it, that it's comprehensive, equity-focused, it's approachable, easy to use, and it meets all the requirements. And so we're trying to do, it's kind of like putting a trailer together. Sometimes it's harder to build that than an actual movie because you're trying to catch everything in there so it pulls you in. So you can go to the movie. So that's the way that our regional health assessment vision is designed to come out as an output. Okay, next slide, please. Next slide. Next. Next. Okay. Oh no, it didn't go into that. It's skipped. Okay. I think it jumped in. It jumped. Yeah. There we go. Okay. So again, this framework here are all the reasons why we work within this space. So there's CCO requirements, legislative requirements, IRS requirements. Again, the MAP framework is the process of mobilizing for action through planning and partnerships, and public health accreditation requirements. Just as Tammy mentioned, Jefferson County just recently received their accreditation because they used our regional health improvement plan from the last cycle. So they really leaned into a lot of that work, as well as our other public health agencies. So this is everything we're doing right now. If you start to the right, that box there, the 2024 Regional Health Assessment, what we did was we have secondary data. If you look at the source, there's 3 sources we're leaning into. In our previous Regional Health Improvement Plan, we looked at secondary data and we only looked at primary data with the listening sessions. So secondary data, what that is there's over 100 health indicators that we look at. These are already data that's already designed from different data sets. And we pull from there and we take the stories that are already there that's aligned with our region story, that's aligned with our county. We look at our demographics and everything about that space. Secondary data could include things like immunization rates, STI, all of the things that most public health information leans into as far as secondary data. Primary data, the light blue down there, at our last Regional Health Improvement Plan, we did 20 to 24 focus groups. We also did the same thing this time. What's a little bit different is that we lean into our core committee and our steering committee. Our core committee makes the decisions and there's representation there from our public health local partners and other health partners. And they make the decisions to say, who do we need to be listening to? What communities are out there that are not being heard. And so we have done a lot of these focus groups. I believe there's over 120 that participated in that. And what's unique around this cycle, if you go to the next slide, is our community health survey. So this is the first time in our RIP, in our regional health assessment, where we put out a survey into the community, and you'll see the results later. But this is a survey that we put out electronically, and throughout the region, we received over 3,800 responses. And we wanted to capture data elements that may not lean in from the secondary data or focus groups. And so this was an opportunity to really hear from our county's specific regions to say, what is happening in your community? Because collectively, we may have a lot of weaved information together, but I also know that we have a lot of information that are separate because our counties look different, which is something unique here in Central Oregon. And so this is the piece where we have actually been having community survey sessions, because a lot of times surveys go out there into the community and you never hear what happened next. And communities feel that you got their information, but they weren't able to lean into the process to develop it further. And so these last 2 weeks, we have held 6 sessions. Tonight is the last one in Madras. And I believe there's already been over 150 people that have participated. I think we have a quick, do you want to play that quick? Just wanted to share something here.
Here, while you're pulling that up, who won the?
Oh, that's the next.
Survey thing.
Where we put it out, didn't capture our QR code before we see the results.
Well, it's clearly the best going to share the price of
Great.
It's
Already starts getting ahead. All of a sudden, the competitive part of me just had to.
Right. And we will have those results today.
Region, your community. Thursday night, the Central Oregon Health Council revealed its findings from a survey launched in March.
And the responses were phenomenal. It was over 3,800 responses. And oftentimes, community members never see the results of those surveys. This is that opportunity for them to lean in and really say, okay, this is what we're saying about our region's health.
The Community Health Survey is a part of a regional health assessment, a report that identifies key health and quality of life challenges here in Central Oregon. The survey happens every 5 years and requires your input. It asks about your level of happiness and your biggest complaints.
It will help us to define in next year, in 2024, our regional health improvement plan to define our priorities to do the investments in health in the region.
The 10-minute online community health survey ended in September, collecting input from community members throughout the Tri-County area.
Just the affordability of Central Oregon, Deschutes County has decreased, and so I think that was a concern from what I saw on the surveys.
Just incredibly important for the decisions we make. It's very easy to get into a little narrow focus and think that you understand the problem. Being able to survey people from across the demographics, especially outside of Deschutes County, is just essential.
Help those with their fingers on the community purse strings to determine where your tax dollars need to go to improve quality of life here on the high desert. Steele Haugen, Central Oregon Daily News.
We provided $50 gift cards to those that registered and attended. We had childcare, and you saw folks with the ear sets, and that was interpretation that was happening, that was available for folks. And so it really felt inclusive, and people really leaned in, and I think we may find more TAC or work group members just even from this. And that was the one thing that we did add as a best practice in the survey is we asked them, would you like to continue to participate in this work? And those that answered, we actually sent those invitations out to them. And that's how we were able to bring more people in. So that's currently where the community health survey is right now. And I know you can't wait for the results, but we're just gonna we're almost there. So really slowly, really slowly, we'll draw it out. So you can start having it. Okay, and then next slide. So there has really been a lot of work in that community survey space and just the work to make it happen so that it's coming into fruition. It will be a huge data set that will complement and intersect with our secondary data and our listening sessions. And next slide. So this is our listening sessions. We had 20 listening sessions, 8 to 10 people per group. We focused on community strengths, gaps, strengths and challenges on health and community forces of change. We also talked about built environment information. So, when I heard that presentation about you may have access to healthcare, but there might be issues trying to get there. And those are the pieces of how do we lean into transportation partners and build that so that access can happen. And so there's really a lot of information that's coming in between this data that addresses those concerns. So, okay, ready? Okay, here we go. Okay. So the 2024 Regional Health Assessment with the surveys of 3,839, the top 4 collecting organizations is Deschutes County, Jefferson County, and Mosaic.
Even with the ask here, wow.
Explain so that there's some places I think you had it too, right, where it didn't register.
Yeah, well, and just there's a lot of people who didn't bother to go that route. They filled out a survey on paper. That's in the association, yeah. They didn't do the QR.
Oh, this actually includes this actually does include the physical responses as well. But I wanted to also lean into the next slide on the left. Because what happened was we actually created some target responses, and although Deschutes County came in first with the volume, Jefferson County exceeded their target. So their target response was 9.7%, but their survey response, they exceeded it to 20.8% for their attendee. So I feel like we have 3 winners here because I don't want Mosaic to feel bad. So I think between Deschutes County, Jefferson County, and Mosaic, definitely leaned in a lot of the survey work out there in the region. So thank you. And really public health, they've been at a lot of these activities and all the volunteers have been amazing. So just wanted to thank the public health.
Yes. It seems like this. I don't really care who won. It's just the community that wins. So I just think that these are great. No, but there wasn't.
For Dan. Yeah, he's already on this program.
There you go. And then the next thing is I'm handing out a timeline. This was a request to see, okay, what's next? What's next so that we can get to the next cycle of our regional health improvement plan. And so if you look at the raw work plan timeline 2023, this is what we just accomplished this year. And by the end of December, we will be finalizing or compiling all of the information for the regional health assessment. And as you can see, a lot of this information is happening concurrently. It's not sequential by any means, and it takes a lot to make this happen. So while the community health survey was happening between March through the end of September, there was data analysis that was happening with our partners and also listening sessions. And the last piece that we did was synthesizing, and we're drafting now all of the results from everything that we captured from the surveys, and also all of the secondary data and also the focus group information. And public health is really working with us a lot on the secondary data in terms of telling the stories around that piece. And so more to come on that, and we'd love for them to present as we move along. And then if you flip to the back, raw to rip work plan timeline for 2024. So this part is, it's a very drafty, very high level. Don't like quote me on any of this because the steering committee, the core committee, nobody has agreed to this, but this is on a very, very high level of what we're seeing. So when I speak to regional health assessment build from January through May, this is putting all those pieces together and designing it, whether it's on a website, a mini trailer document. They don't know yet. We don't know what that's going to look like, but that is the piece. It takes a lot, right, to publish a document that's going to incorporate all of these databases. So hopefully by the end of May, we'll have that. We're also strategizing on what are the pieces in RIP that will become priorities. As you know, our RIP right now has 6 work groups, and those work groups elevated from those priorities. We don't know what those priorities are going to look like yet, but we are going to work with our core committee, our steering committee, internal staff, and other key players to form that strategy. And then, of course, rolling out that RIP planning and gathering, more synthesizing and drafting, and hopefully by January 2024, we'll have a formalized RIP. And of course, all of this will come through here, through the board as well for approval.
Is that, sorry, is that 25? Yeah, it makes it look like a rip in the raw.
Oh, yeah, that should be 20. No, we're starting all over again. Yes, thank you. January 2025. And so raw to RIP work plan, and then moving forward, and that should say 24. So this is, and you know what, I copied and pasted the same. It's okay. So, but that's definitely what that is.
Yeah, who's doing the synthesizing of data? That is a big project. So who's doing that for us?
So the secondary data piece, we're working with epidemiologists in Deschutes County. That's what we did last time. We're also contracting with CoImagine, our partners that did some of the work in the community survey analysis, and possibly Conduent as well. So these are professionals that do this work. They've done it for other regions, and we've also used them in the past.
Yeah, I think it would be great to have Adrienne, our epidemiologist, come and present the work she's put together. And really, I think she's done a remarkable job in other partners and looking at taking the data and telling that story and doing that analysis. I think is really important as we move forward in looking at data pieces.
No, I think will happen here. Yeah. So this is the plan for now. Any questions? Yes.
I'm really impressed, and I want to acknowledge you and the team. Amazing work you've done reaching out to the community and really establishing a new edge, if you will, in terms of community engagement. I wonder if you or the team have any feedback on, was there something that surprised you, feedback you got?
They didn't just show up for the gift card. I mean, really, it was really quite, so there was training involved for the facilitators as they moved around the room. And people really leaned into the data and took a look at it and said, wow, I align with this or I don't align with this. And there was conversation around it. And so that will be captured here shortly. But I think the engagement piece was really fun. You know, just to see community members really care about their health and well-being. So that engagement were built on relationships too. So that we made several phone calls to people that we knew. I'll give you an example. Last night, there was a small community-based organization, and he has a landscaping business out here. And I called him and I said, how many can you bring? He said, I'm bringing 7 people. He didn't attend, but he came. And they all showed up, and I have tons of pictures. I'd love to share more of that. But it was really great. And then there was another family who I said, you know, they got gift cards in the end. And I said, there, you can go on a date night now. And they said, oh, this is our date night. This is what we do with our family. And I said, how did you hear about this? And they found out about it through Facebook still works, social media still works, and all of our other community connections. So just really leaning into a lot of best practices on outreach into the community. So yeah, it's great. Dan.
Just, this is so not a criticism, because I think it's such a comprehensive process. The only thing that I'm wondering is if we had sort of summer into fall of surveying and listening and aggregating that feedback. And then if you could flip the page and it's kind of 16 months from there to finalizing the RIP and have something that is the net like, okay, so where are we going with this, right? That's the RIP. Recognizing the complexity of putting all that together and all the steps. Has the team talked about any downside with that time trajectory being so long, that time gap between feedback and kind of the roadmap?
Do you mean between the roadmap for like 2 years, you mean almost like a year and a half?
Right.
Yeah, you know, honestly, it's a lot closer, and I'll tell you why. Sometimes secondary data analysis and data sets, some of them aren't refreshed until every other year. And so even that alone, secondary data sometimes is a little older. So our community health survey is really capturing the most frequent snapshot. Now, there will be another opportunity because we're going to coalesce all this data again and then go back and say, okay, here's what we're finding for everything. So it's a similar process of what we did before, but there's definitely been a lot more effort. It's almost like adding another layer of work into this than what was done before. But I hear you. I mean, I think it's important to recognize that, hey, maybe we start doing secondary data analysis a year and a half earlier if data is not going to be refreshed, and we move community health survey towards the end of the year. But this was very tight. And so I know the team did a lot to get us here. Yeah, and I mean, they did 20 focus groups within 3 months, and these listening survey sessions we did in 2 weeks. So 4 of them back to back this week. So yeah, and all of the logistics to make it happen.
Is there a part of the process in 2024 where folks would look at and try to understand, you know, from our previous RIP, every time we do a RIP and then try to execute against it, there are things that go really well, there are things that are more complicated than anticipated, there are things that don't go as well. Is there a part of the process where we will take some of the learnings from the current RIP and say, how do we address those in the next cycle?
Right. I wasn't here at the previous cycle, but many of our staff were. And so we're going to lean into our partners also. And that's why that's the strategic planning piece of it, is how do we do this so that we get all the right players in the room and elevate the priorities. That's really the voice of the community at hand, not just because it's an important element of one piece. The other thing, I also sit on the Public Health Advisory Board, is there's a lot of other initiatives that are happening throughout the region. And how do we weave in those goals and objectives together so that when this regional health improvement plan kicks off, we can actually say, hey, because we're meeting kindergarten readiness with Early Learning Hub, you know, this is also a measure as part of it. And we've done some of that work already, actually. So, and then along with our public health partners.
Excellent. Other questions or comments? Okay, well, enjoy the night out. This is an incredible amount of work and super grateful. Bye, Kathy. Bye, Courtney. Thank you. Thank you. So great job, team, and we look forward to more coming in front of us. So next, let's go to, I think we have Erin and Ann. Yes. Central Oregon Perinatal Care Continual Update.
Yes, thank you for having us to come present on a true labor of love. This project has been, I've been in public health for 23 years. I came back, but working with the perinatal population the whole time, and perinatal, prenatal, and postpartum people the whole time. So it's been a true gift to get to work on this project, and thank you to the council for allowing us to be creative and think outside the box and trying something new, taking public health out in the community a little bit. So we can go to the next slide. We originally got funding in October of 2016. And so it was a 3-year project, and then we were lucky enough to have it extended through September of 2023. The project was kind of birthed out of, we originally had a small little initiative that we were funded by Pacific Source And the goal of the original phase one of that project, where we had a public health nurse embedded in one of the OB clinics. And for lots of different reasons, it just didn't work how we thought it wanted to work. And along the way, Deschutes County, Crook, and Jefferson all had a program called Oregon Mother's Care. It's a state program, and the whole goal of that program is early entry to prenatal care and access to resources. And so I was the part-time OMC worker, the only county where we actually had someone dedicated to that work. And I was like, gosh, I think I know I think they might want us in the OB clinics, because way back before the Affordable Care Act, we had a sweet little clinic called Healthy Prenatal Start, where it was for uninsured or underinsured individuals. They would come to that clinic, and I was a little Oregon Mother's Care worker doing Oregon Health Plan, and later I became a nutrition educator for WIC, so I could put people on the WIC program, and I would pair my days on their clinic days, and it worked. And I got to know all the OBs in the community because we worked really closely. And I said, I think it might work to can I try to go to the OB clinics? And it did. What the OB clinics really wanted was someone to help with the care coordination. And you don't need a nurse doing that, right? We want the nurse working at the highest level of their certification, and a health educator could go in and do a lot of those things that they wanted help with. And bringing public health, why public health, right? Is a lot of the services they're asking clients to engage in are the services that we can offer. So that's kind of a little background on this whole project. So we learned that this works, and Crook and Jefferson were like, we really want to do this too. We think it would work. So we got the grant. Next slide. So the whole goal is linkage to community resources by our care coordinators. We call ourselves perinatal care coordinators. So that's a big part of the project. We wanted to create a system that worked in all 3 counties, and we worked together. So regional coordinating, and how are we tracking the work that we're doing? And we also wanted to expand our home visiting services. So in the first year, each county actually got extra funding to hire a nurse. So this is kind of the model. We have the regional coordinator, and then we have the little purple. Some of you have seen this before, but share it again. You have the little care coordinators. They have our perinatal care coordinators work on-site at the health departments, and then we're out in the community. So some clinics were actually embedded. Some clinics are smaller, where we have a referral process set up. So it's a little bit different in each of the areas and what that organization needs or that county needs. So those are some of the provider offices that we've worked with. Next slide. So really, like I've said, the whole goal is how can we improve birth and health outcomes for perinatal women and babies? Well, let's see if we can create easier access and enrollment into programs. We're not only the pregnant person, but also the providers we work with. It's a confusing, web of resources. So how can we make it easier for the providers who are serving this population? So we want to support early access to prenatal care, help support adequate prenatal care, people going to their appointments, and help postpartum patients go back for their postpartum check, along with increasing enrollment into WIC, home visiting, behavioral health, dental, primary care, OHP, reproductive health, and other services. Next slide. So really, we're a true safety net. Our care coordinators are safety net. There's no wrong place to access us. No matter whether we're at the OB clinic or in the health department, there's no wrong point in their pregnancy or postpartum period to access us. We want to create something easy where it's like one point of contact. Go to the perinatal care coordinator, they'll just help you, because it's too hard for the providers to keep track of everything sometimes. No eligibility requirements, no cost. And what we know is things like depression, anxiety, things like being new to a community and not knowing the resources, or parenting in general doesn't discriminate based on what insurance you have. So we want to be open to everybody and make sure everybody knows what's available to them. Some people don't even realize they actually are eligible for some things, like Oregon Health Plan and WIC, even if they have private insurance. So we created, we kind of took a moment to say, what are the things that we feel like are most important or helpful for a perinatal care coordinator if someone were to hire one? And a certified community health worker, being able to help someone with Oregon Health Plan. If they don't have insurance, it's hard to help them get the care. Being able to enroll someone in WIC. We feel like not every area has the ability to hire someone with these backgrounds, but having you know, a bachelor's in some sort of health or social work related field helps, or experience with that. Being able to talk to people and work independently, and just a knowledge of the perinatal health system in the community. Next. So this is kind of what it would look like. You have your perinatal care coordinator. You either get a warm handoff, would mean someone would maybe be a patient at the OB clinic and they're like, walk someone to you. Will you please meet with them? Someone might call and have a scheduled appointment with you. And we created a prenatal screen that some of the OB offices use, where we can, a new patient can fill it out. It helps flag people that might be good for us to reach out to that we might miss in the clinic. So we receive the referral. We assess their needs by phone or in person. We educate, refer, or enroll. And, you know, those are all the sorts of things that we can enroll people into. Next. So we really want to create a model that's just easier. You know, in the beginning, we thought, oh gosh, we'll do all of this at once, one visit. We'll put them on WIC, we'll do it. That's just too much in one visit. So we said, we want one point of contact, because the medical system is hard to manage and understand. I mean, even for myself, right? I mean, I grew up going to the doctor once a year and going to the dentist every 6 months. And I feel like that's a privilege. Not everybody knows you can have insurance, but you don't know how to use it. And so that's where we come in to help people understand the why. Why do you go to the doctor once a year? Why do you go to the dentist? And you know, they don't even know what to say on the phone. So that's what we're there to, is make it easier. Next. Well, here's a little data. Next slide. So this is a busy slide. You can look a little closer on your little packet, but the stars you'll see is where our employees started, our care coordinators started. So you see numbers going up. In the beginning, we were only really tracking prenatal clients. We actually, the Oregon Mother's Care Program was kind enough to update their whole tracking form for us, so we could use it for this project to keep track of all the work we're doing. So they were great partners with this work, and we asked them nicely if they would make a postpartum tracking form, and they did. So you see, we were serving postpartum clients before, but we were able to start tracking the work. Next slide. So, you know, one of the big metrics that we were looking at is how can we help this area continue to have high rates of early access to prenatal care. So year one, quarter one, when we first started, the Tri-County, and the average of the Tri-County, we were at about, just with the clients our program was serving, this is not the Tri-County data, we were at about 75% of people who we saw originally in their first trimester. How successful were we at helping them access care in their first trimester? Because we know how important that is. So we went from the very beginning of the project, 75% accuracy, to we're at about a 96% accuracy of this last quarter is what we came in at. So I think that's a huge success. We average about 93% of the people that we serve who come to us in their first trimester get an appointment. We also kind of set up a system like, well, what if they see us in their second or third trimester? We feel like getting them in within 2 weeks is our goal, and you see where we're at. And then the breakdown of the different counties. Next. And we wanted to take a look at how are we doing and compared to the state of early access to prenatal care. So looking at the state Oregon Vital Records, it's only through 2021. as you know, they play catch up there. We'll get, takes a while to get it, but you see we're the purple and then the kind of pinky purple color. Sorry, they're so close to the same color looking at it on the screen here. But you see, we started out pretty good. We had a dip and I was like, why did that happen? Oh yeah, we lost a whole OB clinic when we first started. And in a small community, that really impacts people accessing care. So, but you see, with our relationships with the OB providers, I think us being able to say, hey, we're having a hard time getting people in, they made adjustments. Planned Parenthood started seeing OB patients. I mean, the community in general shifted, which was pretty awesome. So then you see where we're ending now. We're doing, the Tri-County is doing pretty good compared to the state. In general, Oregon does pretty good, but I would say we're doing great. So next. And I won't spend a lot of time in this because of time's sake, but these are all the services we are helping people access. So we've kind of broken up how we do our work. We educate. A lot of people might say that's a referral, and I don't believe that's a referral. We can tell people information, but actually helping them get there, like get to the appointment, I think that's a referral. So we kind of broke apart, like how many people did we talk about services with? How many did we actually help get there? And like, not everyone's going to accept your help. And so, but that's kind of looks at, we're doing dental, we're doing childbirth education navigation, home visiting, transportation, behavioral health, other community resources, breastfeeding, primary care. We spend a lot of time talking about primary care, a lot of time in dental. We do a lot of WIC enrollment, so you can just see the different services that we're doing. And I would say it started small in the beginning. You have to train staff and understand, and we focused a lot on prenatal. So I think the quantity, and now we're really like looking at the quality of service. What does someone get over time? And that's improved as the years have gone on. And the work, everyone's still doing it, which I'm so thankful for. Doing a pilot project is hard, and we haven't lost any care coordinators yet. So yay. So thank you to the team. So next. This is the same thing, but just showing what we're doing for postpartum. Next. So looking at improved outcomes, there's no like study on us saying if someone sees us, this is going to happen. But we do know services that we refer people in that are evidence-based. We see that there are like WIC participants, 17% less likely to have high blood pressure during pregnancy. Nurse family partnership, home visiting, 18% fewer preterm births. So as you can see here, like this, why are we important? Because we're helping people get into programs that reduce risks. And overall, I just put on the bottom there, we've served in the Tri-County area through around the beginning of the project through 2021, a little over half of the births in this area, which is pretty great. Next. So program accomplishments. Next, sorry. You have to click the thing. Okay. Yeah. This is something I'm super proud of. We created the community baby shower, and what's crazy, we did it 2 years and we're still getting phone calls. Are you doing the baby shower this year? It was so fun. It started with a little idea like, oh, let's just have a little baby shower in a community and we'll just get all the community partners and celebrate people who may not get celebrated. And then this is good for the partners. They can all communicate and chat and share info, but so great for our perinatal people to come with their families and learn about all the resources in one spot. Well, those of you who many of your organizations did participate in it. The first year we had 6 different locations in each area. We had La Pine, we had Pineville, we had Bend, we had Redmond, we had Warm Springs, and we had Madras. And we served over 800 people attended all of the baby showers, and we had a little over 400 actual prenatal or postpartum people there. And then we had even more in 2019. So it was an incredible just community event, which was really part of this whole project, bringing our tri-county together. So it was so fun. I wish it could be a part-time job for someone putting that on. We don't have the capacity to do it now, but someone should. It was a really fun event. So hopefully that can be reinstated, but the council helped fund us, gave us a little bit of money to help do that. So thank you. That's additional to the funding that we're talking about here. We create a resource collaborative. We have over 100 community partners that quarterly get on a call where we share resources, education, coordinate, ask questions about different services, all those people that are just working with the perinatal population. And that was a big goal of ours, is how can we again bring the community together? And it's tri-county. All of our staff became community health workers, which there's been a big push for that. And so we decided, gosh, it'd be great for billing purposes if we could all become community health workers. So we're all certified health workers. We're documenting in the EHR system, so medical records. And those of you in the medical field know how important that is to show the work you're doing and for coordination of care. And people say if it's not in their medical chart, it's like it didn't happen. So it's really cool that we're able to chart all of our work in the EHR systems, which really helps with coordination of care and duplication of services and all those things. We created different billing pathways for the work that we're doing, so we can now bill as a community health worker for the safety net work we're doing. And we can partner with the nurses. We talk about working at the highest level of your certification. We can help the nurses increase their caseload by our community health workers supporting with resource navigation and all the things we're talking about. So they can assign us tasks and we will do that for them, which allows them to see more people. And what's great, we're the ones that referred that patient to the nurse home visiting program, so we're all part of the same care team. Next. We've got an online referral system. We've strengthened our coordination with behavioral health, the dental CCOs, we work a lot with them. Pacific Source has been incredible. We have them on speed dial to help clients with care coordination or hiccups. And just in general, the 3 counties, we work so closely together. And as a lot of the patients we serve cross county lines, so knowing that I can refer someone in Prineville who's accessing care in Bend at East Cascade Women's Group, I can refer them back to the care coordinator in that community so they can get the support they need. And just system-wise, like setting up systems and structures and workflows, we've worked really closely with our teams. So we're really mirroring each other. Next. We worked together with OHSU. We did a qualitative evaluation. So now we can use that and every few years to see how we're doing. We created a program handbook, and I actually brought to bring them up here, that just lays out everything that we're doing for the work. Referral pathways to OB clinics, even some of the ones that we're not physically in, like Mosaic. Anyone who pops up who's pregnant in Mosaic, because we share the same EHR, they plunk into a referral queue for our team. Family Connect, some of you have heard about it. It's universally nurse home visiting. It's offered to everyone, such as we're offered to everyone. So we've worked really closely with the rollout of that. We're kind of their number one referrers, and then we can help them, access postpartum care and work with the nurses in that way. And then we are called on a lot with the state with OHP access issues. They've actually asked our perinatal care team to sit on work groups with the state. Next. We were invited to speak about this work at OHA's Innovative Cafe, and really exciting, Clackamas County just hired their first perinatal care coordinator. So they have adopted this model. And then just all their collaboration with the state, they've changed their whole tracking method to help us. So next. Program challenges and lessons learned. Sorry, I don't know how we're doing on time. You're just like, okay. Integration, I think I was kind of Pollyanna in the beginning saying, oh, well, I'll do it this way and it's gonna be great and it's gonna be well received and everyone's gonna love it. But what I learned in every medical clinic runs differently. you know, so we had to, but the goal of accomplishing our goals of easier access and enrollment when she does not fit all. So how we integrated in the different clinics, it took, you know, a lot. We're still working out the kinks. You're always working out the kinks, right? And then what we found with the health department, we thought, oh, this is gonna be easy at the public health department. We work with all these people, but what I'm learning is public health, a lot of these programs are so prescribed and they've been around forever. So here comes this new program that overlaps between other programs and people are like, well, what, we haven't done it that way before, you know? So just change is hard. And it's, you know, so it's been really great to work together and get people out of their silos and things like that. Our poor little team has multiple places to document because they're doing WIC, they're doing they're helping people with programs that use systems that don't talk to each other. So sometimes they have to document in like 3 different systems. So that's not fun. So again, they're still working, they're still doing it though. We have all different billing and charting pathways just for us to get a little bit of funding. So how we serve someone, which program, it's a different way that we have to chart and bill. In the beginning, our staff were spending like half a day at an OB clinic and then they'd rush back to the health department. So just the different locations and moving around can be hard. COVID, I don't need to say any more about that, but I think we did great, quickly accommodating and still serving the population. Just the constant change of a pilot project. We're just trying things out. So, you know, I think being flexible, but it's hard. It's hard. So and the world changes, right? So systems change. So just hanging in there. And then the big one is just sustainability for the care coordinators. I really do think, you know, we have nurse home visiting, we have all these programs that can bill and do all these things, but I think there's this magical part of the safety net service that we're offering that we just can't sustain the work we do just based on being able to bill as a community health worker. It's, you know, we definitely have braided funds where we're funded lots of different sources. So there's a big push for community health workers, but the reimbursement rate is just too low to really sustain for that to be the sole sustainer. So we're always looking at ways to keep us alive. So next. So what are we sustained by now? We use our Little Oregon Mother's Care Fund. So OMC, that's what that means. I probably should have spelled that out. Each county gets a little bit of funding for that. We do MAC, so Medicaid Administrative Funding, claiming, and then we have our community health work billing, which was so exciting, but the reimbursement rate's pretty low. And then we do our nurse extender where we can actually bill at the same rate as a nurse, but the nurse has to see them first. So there's some people that we're helping that fall through the cracks who don't want to engage in nurse home visiting. So, but we're there, we're filling that gap. We're case managing them. And then we're supporting Family Connects, which brings in some funding. And then just looking at like, because we're such a big referrer into all these different programs, what is the value of that, of keeping us around? And that's where some other funding, general funds, things like that, like they feel like we're important enough to keep that alive. So next. So yeah, this has been, you know, just an incredible project to work. And I hope to see it continue to grow and change. So thank you.
Wow. Thank you. That's incredible.
Yeah, how many care coordinators are
there? We have 2 full-time care coordinators in Deschutes, and I help a little bit with that work. And then we have 1 part-time care coordinator in Jefferson and 1 part-time care coordinator in Crook. And they're really, the care coordinators in Crook and Jefferson are kind of funded in different ways. So they're supported in Family Connects, and they're, you know, so they're from different programs. So they might be helping more hours than that, but yeah.
And how many of those are Spanish speaking?
We have 2 that are Spanish speaking.
Great.
1 in Jefferson and 1 in Deschutes.
Thanks.
Yeah.
Really good.
First of all, amazing, thank you for sharing this. And one of the reasons I sit on this board is looking at the link between health and education, and was wondering about the partnership with early learning, big part.
Yeah.
Does that look like it?
Yeah, we work really closely with them, so we refer clients back and forth with them. They sit on our collaboratives meetings, so yeah, we refer back and forth all the time. It's nice that we have that collaborative meeting so we can, you know, how's everybody doing? What's anything new happening? And so definitely, yes. Great question.
Awesome presentation. I love the outcome slide. Those are powerful outcomes, right? Preterm birth reduction, abuse reduction, or increase in breastfeeding at 6 months. Do you know the number approximately of your programmatic financial gap for 2024, say?
We can get
That's above my pay grade.
We'll just say, I mean, this to me, when I came in here, this is one of the most innovative programs that public health has I've seen in my 20+ years in public health. And the fact that like Clackamas County came to see how we do this. And it really is the innovation we were able to do because of the Central Oregon Health Council grant and the extension of it for 7 years. I will say we don't have that anymore. So this next fiscal year is really looking at sustainability and all those kind of different funding mechanisms that Erin was talking about. But yes, we are committed to trying to keep this going. It's a shoestring right now with the staff. I mean, they're all over the place. I think we could use probably 2 more of them in Central Oregon.
Yeah, another question was your 54% of total births, which is really impressive to penetration rate, but is the limitation from 54 to something higher staff or something else?
Oh, yeah, like if we were instead of the larger OB clinics, if we were able to have whole bridge there, we would be able to reach more. Definitely, you can always see more people with looking.
Mind wanders, this question we always ask, are pondering grants, and we used to sit in the boardroom and ponder grants, we just haven't been very good at that, so we delegated those functions to better places like CAC and RIP, right? But we always ask if you can hit, you know, what outcomes can you hit, and if you can hit certain outcomes that have a quantifiable benefit, then sustainability should be kind of a no-brainer. It's just about which pocket. This program feels like it is there with respect to the answering of that question quantitatively. So I'd love to see, for me personally, that how does this connect to the maternal and child work group or whatever? What's the cost of one term birth avoided? It's probably more than your programmatic gap. By far.
Yeah.
So just amazing work, and it's not left out.
Well, I will say, you know, 54%, that's approximately kind of how many Medicaid births we have too. So hopefully that means, I mean, hopefully that means we're reaching, and not to say everyone is important, but what we can help people enroll into, like WIC and things like that, that can really be helpful. Hopefully that's our, you know, definitely we want to reach that population.
Well, we desperately need this program because I know the last 70 days, we had 6 fentanyl babies born in St. Charles. I'm waiting to get the year number, but you know what you're doing is so important.
Thank you. Yeah, it's a complex system, and I think a big part of it is serving the client, but bringing the community together and working together to, you know, so we're not in silos, we're collaborating. So working with the Best Care Moms program, we meet weekly. So yeah,
I think you hit all the pieces of what CCOs are trying to accomplish. You know, you have integration, the innovation, and the collaboration and advocacy for best practices. The other piece too is, yes, we can quantify, but there's also this social capital and you know, this qualitative piece that these mommies are getting that they normally wouldn't have had. So I mean, that's always we measure that.
right. It's that's what we always end up coming back to is how do you measure this piece, the warm fuzzy piece that we're helping someone feel safe, and we're helping them trust us in therefore they're engaging in services, and we have the tools to help them engage in those services.
And we have that belonging studies now that are happening.
Yeah.
It's part of.
Yes.
Just to add to this, really important, when we did some work down in Plymouth Falls at Advantage Dome, we found that case coordination was the key to getting people started. Secondly, we did a program where we got pregnant women in and lowered their disease level because infections, which folks don't know, one of the reasons why people have pregnant babies. The most common infection in the pregnant woman in Medicaid is infection in her mouth. And if you're going to lower that disease load, you have better outcome. And when we did that, and for kids, the babies through the program, we actually studied the ones in Plymouth Falls, and we compared it in Plymouth, Deschutes, and Jefferson County, and we actually lowered the amount of tooth decay in 2-year-olds by 50%. Just by case coordination. We had 2 studies, one in Plymouth Falls. You know Charity Ludwig, if you're in the area, that's where Charity started. He ran that program. And then we did 6 counties where we did, and what we found, the only statistically significant thing was case coordination. So that's just the one.
Well, thank you.
Powerful.
Thank you.
Yes, and also the fact that you are helping your own colleagues think differently about where they are in the system and the importance of their work. So I also wanted to say thank you for, there's that piece of thinking differently as what you've always done and what you might be able to do in the future. There's a risk there. And I don't want it to go without being said the moment when you were talking about, bringing my own colleagues together. This is what public health does, and this isn't what we do. But in that space is the change. And so I suspect that was easier said than done.
Yeah.
And so well done.
Well, and kudos to the whole, every partner, every team, all the teams we work with. I mean, we couldn't have done it without their support. So with in-home visiting and just public health leadership and all of the OB provider clinics. So yeah, it was definitely a group effort.
Awesome.
So Erin is very humble, and I will say that you have been the constant, and it truly is a labor of love, and Erin.
Yes, great job. I'm sure you can say, Sticky to them, make try on, it smelled like chicken Dan. Thank you, Dan. Service here with 5 stars. I know we're a little bit over time, but you were just, and I got the next 2 agenda items.
I'll see if you can't make up a little bit of time.
Yes, but don't feel rushed, please.
Okay, thank you. 2 addendum items today, starting with the 2023 CCO performance metric. We are on our 3rd quarter. And I think it's important to share that this presentation, how we share this information with the board, has been a work in progress. I look at this single page in the packet and I think, if I was a board member, would I really have dove into this information? And I'm going to cover highlights here today.
It could have been printed a little bigger. A font smaller?
Right. It's probably fitted on 1 page, right? Or before it's on 4 pages and we didn't love that either. So I think when we talk about this as CCO directors with Eric Taylor, our vice president, I think we envision this in a future state where we break out one of these metrics and we have a deep dive quarterly into that metric, what it impacts, the work we're doing in that space, how it overlaps, where does the metrics, where's innovation in those spaces? So I'm saying, I think, bear with me on Q3 and Q4, and remember that you all have the spreadsheet that this was attached to, which came with considerable information, including, defining the mental health service, value-based payment, the ED utilization metrics. There's a glossary of information, so when you can't sleep, that's where you go. And just know, again, we'll continue this as a work in progress. So with that, I'm going to report out on 6 items on this big sheet of paper. So let's start with the very top, which is our QUIM work to meet a minimum of Oregon Health Authority quality incentive measure targets to achieve 100%. I want to tell you that we're doing pretty well right now in that we have met adolescent immunizations, childhood immunizations, dental and oral services ages 1 to 5. We're really close to meeting the dental and oral for 6 to 12. There are a couple of measures that we are working on. Postpartum metric is one of those. We're also working on oral evaluation for adults with diabetes. We are cautiously optimistic, and with Lori Hill here in the room to say our well child checks are on target, but we have not met them yet. So we are cautiously optimistic there in that space. It is unlikely in any quality incentive metric reporting you would ever see a green box until the year is over. This is sometimes done one member at a time on December 31st to ensure that we're meeting these measures. So just not to be alarmed that you continue to see yellow there. There is tremendous amount of work being done in this space. I'll share that there's a Central Oregon Health Council quality incentive metric work group that meets high level and collaborates on work in this where there are best practices opportunities, where clinics are having success, where additional work and focus needs to be done or can be done to ensure success in this space. Additionally, Pacific Source meets monthly with all of our provider partners. We're providing very specific member level detail to our clinics so that they can reach out to individual members who may have not been seen for the service that's needed to achieve that measure. So a lot of work being done by a lot of people, and to see that we have met immunizations for childhood and adolescence, we should really just pause and applaud the room.
Oh, wow. Oh, wow.
Yeah.
This match looks different.
A lot of great work happening there. I'm going to drop down to the next measure and just celebrate the percent of members with mental health services who receive a mental health service in the measurement year, that we are seeing some improvements within our Latino Latinx member population. And although that's a slight improvement, I will tell you that there are some significant interventions being put in place here. There is an emotional health campaign with 6 complete strategies to help improve this specific population access. Some of those efforts include interpreter training in Spanish, trauma-informed care training for our community partners, attending events like the Latino Fest in Madras. So a lot of work being done across departments here as well to impact that measure. And again, while I would say that is yellow, our 66% goal is a self-imposed target that, in fact, OHA has not yet set a statewide benchmark for this measure. So we imposed a 3% improvement target over the previous year, which is a standardized methodology. So although we are not, we are yellow in this space, there's a lot of work being done, and we don't have a OHA target yet. So we will continue to update as that unfolds. I'll drop down to all the way down to the financial stability. And I just want to highlight that the Central Oregon CCO has exceeded 77,000 members, which is amazing. We have grown considerably during the public health emergency and have continued to do so. And that with that high membership, we have also been very successful in our CCO financials, and I'm happy to report that the Central Oregon Health Council has received just over $10 million in shared savings, that 50% will be reinvested back to provider partners, and the remaining 50% will go to our behavioral health investments that Carmen and the Health Council team will shape where those investments go. So that's, I think, really exciting. And then the last note there is also that we continue to be in a shared savings position for I just lost where that is, for 2023, right? Currently trending at just shy of $7 million. So it looks like next year we will have that benefit as well, but we don't close the financials in 23
until well into 24. July or August of 24 will be when that will be finalized, but I will continue to track that. We track that monthly at the finance committee meeting as well, so that we will see how we're doing at the end of the year, but that's where we're at now. So I think that's worth calling out and sharing. In addition, to our continued incredible well management through our ED utilization measure. If you can recall on that large spreadsheet, the bars across the bottom, and matter of fact, I wonder. I won't share screen, but the emergency department, we had a blue and yellow and red. I could share here for those in the room. And we are trending at a better rate in our ED utilization than we have ever annual. So the 390, our next best was 398, and that was in 2021. So a lot of incredible collaboration and preventative work being done across our communities to see managed ED utilization outcomes like that. Wow. Yes, it's incredibly exciting. I'll drop down to the last two in operations, and I just want to note that although there was an increase in our non-emergency medical transportation percentage increase, that it wasn't a numerical increase, so no more people complained. We just simply had let me read this. An increase is not due to an increase in any EMT related complaints. Rather, it's a reflection in overall decrease in complaints during that quarter. And there's a little bit of lag in this. So we're actually looking at the second quarter results. So it's worthy of knowing that. And we did have a slight increase in oral health complaints. Having said that, we are still well under the there. So in a snapshot, that's the information. Does anyone have any questions specific to that space?
Kelly, I can't see.
There's no.
There's, okay, great. So for those of you on the screen, we can't see you. So if you have a question or something, please feel free to just interject. Any comments? Oh, Brad, sorry.
Yeah, hi, Tricia. Just a couple of questions. I know this one about mental health has been on for a long time, and the Laura's kind of puts it in the outcome. So just to clarify, does this number mean 66%? Does that mean that there's 34% of the people who actually express that they have a mental health need do not receive a service?
Correct.
Why is that number so low? It seems large to me.
Yeah, I mean, I think we could do a deeper dive, but there are referrals that people are offered, and in fact, they never access the care in that space. So we could do, I'd be happy to come back with a deeper dive in that space, but really what we're just ensuring in this space is that anyone with a mental health event is offered and gains access in that space. And some of the why the Latinx Latina population was identified as an area of opportunity because there was less utilization, less access in that being reported. So you can see that in the, I don't have it up in front of me, but the 52%. So yeah, trying to bring that up and having a lot of conversations around cultural variances to accessing mental health, whereas what the reports that we are receiving back is that a lot of that is handled within the family. So even if a referral is handed, they say, we're going to handle this within our family instead of go to the professional. So there's many varied reasons in that.
Okay. We might have really feels like that's a big number.
No, I think it'd be great to have that deeper dive. Yeah,
Is that either the national code?
Yeah.
And pediatrics, the number is about 12 to 17% higher than that. Because the demand is so high.
What do you mean? Sorry.
Because the demand is so there's just not enough behavioral health workers to support the requirement. Yeah. Things like suicidal ideation have gone through the roof since the beginning of code, and they were doing that great before. So this is actually basically compared to national number, and I realize that's a blend of pediatrics and adults, so it's not straight up. It's actually a lower than things.
I'm also curious, Erin Fair Taylor, if you have anything to add in that. mental health conversation? That various.
I think that you gave the best information that we have. Definitely a lot of energy and attention being paid here about ways that we can grow the workforce, add capacity, better understand the need, add the type of workforce that we need that's matched to the need. But it's not a quick fix, unfortunately.
Thanks. And then just one other question on the ED utilization rate. I'm just curious, being a skeptic, in this case. It seemed like for long-term families going to the emergency room can be really expensive. Bring to the emergency room, to take an ambulance to the emergency room. So I'm just curious, like, how do we parse out how much of that lower utilization, like what's causing that? I guess my question, like, could there be a segment of people who just avoid doing that because of the fear of debt, fear of what it could cost, fear of.
I mean, without a doubt, that's some of why when I look at the chart, we had some great low ED utilization during the pandemic. So, but also we're hopeful in that space that people were retrained, that we made better connections with primary care providers. And through those improved connections are able to do more preventative care, thus decreasing eventual use of ED utilization. I mean, I think that it's wise to continue to ask why in that space, and to help ensure that we know that our members are accessing primary care providers. A great example of that would be our new Healthy Oregon program members, people who have likely never had health insurance preventative in the past. So how do we help work with that population to help ensure that we're establishing with primary care providers and understand the card that just showed up in the mail at our house, and what that card represents is access to care, not just in the behavioral health realm, but also dental and also all of that work. So, and then eventually, you know, there could be other benefits associated at member level, right? You need a gym membership. Can you imagine a HOP member saying, what, I could have a gym membership if it would improve my health? So yeah, I think it's important to ask those questions while we review the data. So
Make sure you have to see that number actually, based on ethnicity, to see if that has an impact.
yeah, and I think it would be worthwhile to bring Carly likely back in and have another conversation around this, because I think what I can hear her in the background of my head saying is that it's factored in.
It's a really good point, especially with the population, because that understanding of your benefits, especially if you've never been benefits, even if someone's like, no, you're somewhere, they're gonna be like, right. It's like you think you can only do some education, and certainly benefits. There's other ways that we could do education. It is a complete game changer and understanding. And I love, of course, no, I can't do that. Yeah.
Great questions. Mike.
You mentioned dental twice. Does anybody in the room not have a dentist that they can go to? Anybody in the room? And that's a, it's because you don't have one, or you can't afford one, or kind of got that. You could if you chose to. My point being is, how many go to a dentist that actually does Medicaid? Do you know it? Most don't. How many think Medicaid dentistry is really working at the level we want it to? Okay. Most of dentistry doesn't participate in Medicaid for a reason. That's because the model they use doesn't work. Well, maybe we ought to think about, rather than doubling down on the system that doesn't work, maybe we ought to think about a new system. And we now have a medicine that you can put on a tooth at a cavity that actually stops that cavity and all cavities in the future. So maybe we ought to rethink the system rather than double it, because everybody in a room, and this goes to diversity and equity, everybody has a mindset of what dentistry is, but it's wrong for the population that we all know doesn't work. Because fixing the end of the result on a population whose disease is out of control will always fail, regardless of whose hands you put the drill in and how expensive it is. The system's broken, and so rather than double down, because I hear us talk about dentistry and I take it personal to heart, because very frankly, I should be retired spending money. But it bothers me so much that we're still doing the same old thing. We're still, in a way, beating up on dentistry because it's not the way we want it to be. And all of us think we know what dentistry is like, but none of us think Medicaid works. I had an opportunity to speak in Chicago about this. And everybody in the room said the same thing you do. We all have a dentist, we all know what dentistry is like, but it doesn't work on Medicaid. Maybe the system we use on a population with diseases out of control doesn't work. And we ought to rethink it.
So do you have a pilot in mind?
I mean, yeah, literally,
Yeah.
I mean, don't get me started. I could spend the next 3 hours talking about that. I'm actually working on one in New Hampshire right now, because they just started adult dental on April Fool's Day this year. The appropriate day. Because you know what all the dentists said? We can't afford to take Medicaid. You don't pay us money. And truth is, there is no more money, so how do we do it different? Vanny's Dental does that. Not like they used to when I was there, but they do it. That's what they're trying to do. That's what they're trying to work on. And part of it is the fact that who has a baby? What's a childbearing age? You know, Megan, what is it? 15 to 35, most people having babies. Most people having babies. They're making- We got all of those people in and Lord do disease load. Their kids wouldn't get cavities, wouldn't do anything else. Wouldn't even have to worry about kids if it's been programmed for kids. You just get those that might have a baby, do a risk assessment for their disease load, and guess what? If you did, we proved down climate policy can lower the amount due decay by 50%, and we weren't even very good at doing it. So my point being is I hear it, and we just have to rethink it. And I'm sorry for returning because I just.
That's good, thank you.
There's a whole movement of what to do it different, and you guys are working on it. You guys are working on doing it. But problem is we go to the committee meetings and we go back and report to our bosses, we're working on the problem. So we've done our job. We didn't solve the problem, we worked on the problem. We're working on the problem, all of us. When in all actuality, we now have stuff that would like to solve the problem. I'm sorry.
No, that's good.
When you start talking about oral health,
Thank you.
my
Yeah.
blood pressure goes up.
On that first, I love the idea of getting so far upstream that we're treating pregnant people before we have children to improve.
You're asking 5 questions, you know, for a child, a person of childbearing age, ask them 5 questions. If they answer 1, the child's at risk for having tooth decay. Right there. We know in Klamath Falls, 40% of babies being born were on Medicaid, and 40% of those were the average age of 15. But we know what the issue is, and we know how to solve it. We just, the bureaucracy and the way we go about things.
I'd love to share one little bright light in this space, and I have it under the word innovation here in my list. And that is with the support of Capital Dental, we hosted a mobile dental clinic in the Pacific Source parking lot. And the target for that specific population was adults who needed an exam, who had diabetes. So working with Capital Dental, they actually had a couple resignations, if you can believe. So we planned the event, they have a couple resignations before the event. They say, we're not canceling this. We have people who are coming to the mobile unit. So they pulled staff from the valley to come over to Central Oregon to do this work. They saw 16 people, want to do it 4 times next year. But this is like let's try something. I think I heard this out of the June. They're like, let's try something. Let's see if we can impact here, connect them with their dental care organization from that point forward, and help ensure that we're doing more than reporting back that we're making a change, but it's slow moving system. I hear that. Perfect, that's right there.
I know COPA did that integration with assessments and screenings now when pediatric child was.
They do it every year too. I think you just need a dentist every week.
Yeah, there you go.
No.
I've been a student dentist. I have time. People have dental anxiety, especially the relation you're talking about. Even getting to there. They're
Yeah, 50% of people don't know here.
be scheduled with behavior health appointments a bit. Get it.
So there's a lot to unpack there. We might also have TAC involved in some of these ideas too, so.
Are we ready to pivot to redetermination?
I think so, yes.
Okay, thank you, everybody. I'd like to just start with a few highlights. We can go ahead and jump to screen 2. Slide 2.
Oh. It's showing on my screen. Hold on.
I'll start while we wait for it to load. So in September, you'll see numbers here of 76,000 membership. We have now exceeded that. As I reported, just over 77,000 members in Central Oregon, likely to be our peak. Important to note that the Central Oregon CCO grew 40% since the public health emergency was declared. Just a reminder that Hotel California, where once you got in, you stayed in until the health emergency was declared over. And that's what redetermination is as we're going through. OHA is going through and redetermining who is eligible for Medicaid. We're anticipating about a 6% reduction in 23 to be followed with about a 19% reduction membership in Central Oregon by 24. So when you add those two together, you're looking at about 1 out of every 4 members no longer being eligible for Medicaid when redetermination is over. Let's flip and take a look at some trends. Next slide. October was the first month where OHE disenrolled individual who did not respond to any renewal notices. So remember, this is a very mail-heavy system where notices are going to go out. We're going to review that timeline, but October was the very first month. As that occurred, we experienced about twice as many disenrollments as the prior months. We're anticipating this to continue for about the next 4 months going forward. And also just an important note that many members who are disenrolled are still eligible. So remember that they're procedurally disenrolled. It just means there was no information came back from the members. So they are still eligible. This is an entitlement program to submit information, and depending on the window that they do, they may be able to continue to answer questions, or they may need to complete a full application. So next slide. So this is that slide where if we walk it back, you can see the starting point is April 1st. First, the number 1, as you followed along the timeline, was when first reminder notices went out June 1st. A second reminder notice went out to the members from OHA on July 1st. And at which point on August 1st, the first notice of closure was sent to members who did not respond to any information. At that point, the members had they had 60 days to submit information, and if they did not submit, then a renewal closure happens. But wait, this is the state nice part. That's not all. The state also graciously leaned in and said, we're going to allow a 90-day window called the 90-day reconsideration period, where if the member responds during the 60-day adverse period, they can proceed without any interruption in coverage. After the 60th day, benefits will end. The member will still have this 90 days to respond and resume to the renewal process. However, there is an eventual end date. So when that 90-day period ends, then the member would need to submit a new application. So there would be no additional back and forth with the state. But again, it's an entitlement program. So if people are eligible, they can apply and get benefits.
I have a quick question.
Yes.
if someone has not responded to any of the notices and then ends up needing care, an urgent care center or doctor's office, either during the 60-day adverse period or the 90-day reconsideration period, are they automatically re-enrolled? An eligibility determination made, or are they in bad luck?
It may depend where exactly in that process what happens. Erin, would you mind leaning in and speaking? But my understanding would be they would do a benefits check and be eligible for coverage.
Yeah, so if they need care during that time, they can re-enroll with the help of an enrollment assister. As long as they're still eligible at any point in time, they can enroll. It's not like commercial or Medicare where they have to do it during an open enrollment period. So even if they're past the 90 days, if they are eligible, they can re-enroll at any point in time. Depending on the place of care, the state sometimes will reach out to us and say, hey, we have a member that showed up. Can we retroactively enroll them to the first of the month with your plan so that any care that they've gotten during the month, will be covered by the CCO. Sometimes the state will cover that kind of care episode fee for service and then enroll the member after the fact, but it all is sort of context specific. But the point is, if they're eligible at any point in time, they can re-enroll.
For that clarification, Erin. Can we go to the next slide? So here are some numbers. So when we look at July on the right side of the slide, we see additional numbers, and this was occurring when the Healthier Oregon program members were transitioning in the age group from that was included. So all ages are now part of the Healthier Oregon program. So we saw a gain in membership at this point in July, and then we flip over to the reduction in membership. August, September, October, Central Oregon is highlighted on the left. So you see about 1,200 members a month until October, where we hit 2,000 members for the month. I'll tell you that we also have November information that came out after I sent this slide deck to the board. We had anticipated numbers to be around the 2,000 mark. And in fact, we had a reduction of about 1,100 members in Central Oregon. So it was less than we were expecting. There's potentially a few reasons why. CMS asked OHA, Oregon Health Authority, Center for Medicare and Medicaid Services to hold redetermining a few populations. So that hold may have resulted in a decrease beyond what we were expecting. But we're trying to identify trends in a month's worth of data. So we're going to need a little bit more data to know, is this month a strange month, or is maybe October was higher than anticipated? And what does this mean for our eventual total outcome in this space? Can we go to the next slide? So here's just a slide on the overall. And again, this is slightly updated with October data. The state has now redetermined over 800,000 members. Most are continuing their benefits. So you look over 82.2% have continued. Benefits ended if you drop down for 14.3% of the population. So, and again, that's statewide data. So good news at the 82.2% of members continuing. So remember, our initial projections were about 25% decrease in Central Oregon. We did rise higher. We may fall lower, but this is looking like the impact potentially could be less than 25%, which would be exceptional if that happened. What's the benefit reduction? Yeah, that's a great question. My one-on-one with us that covered this. I joked with him, I'd pivot to him. That question came up. But really, membership reduction in this space is really more speaking to the population. For example, members 138 to 200 percentile may have had some benefits that, because they're in that higher income bracket, they no longer qualify. So meal delivery.
Long-term support is mostly that group population.
really, yeah, maybe some medication assistance kind of components of a nurse visit at home, that sort of inspection of the home or to really medication, what's it called? Make sure we're in the right box.
Is that
Yeah.
go under design, the basic health and benefit package?
It should be here. I'm not sure exactly how it's in but yeah. Yeah, but most of that 138 consumers.
Yeah.
If they were.
So that population stays on Medicaid and then transitions over to the new basic health plan, July 1 of 2024. So, yeah, great call out on what that percentage is, so. Thank you. We can go to the next slide. Our messaging remains the same. There have been a handful of errors, as you could imagine, in a process like this, where people receive letters that both they are maintaining coverage and some receive letters they lost coverage. Neither of those are actually true. So it's great. This is the first of its kind, over 1 million people. I just think it's so important to just remind people, first of all, mail heavy system, please have them call Pacific Source. We are answering the phone. This morning's meeting will tell us, I think it was 187 seconds it takes to get to a live person. Yeah, I know. So it's like 3 minutes for people who don't count in baby months or seconds. So there's that. So please call and we can update it in the one system and help ensure that people are getting mail. Two, if they have any questions, please seek assistance. Just reminding them to bring in their paperwork to the health centers, reach out to enrollment assisters. There's a link, live link here in the packet where it won't be live for you because it's paper. Clicking, yeah, well, it should be live and webinar, yeah. So please click there and you can find an enrollment assister. So please just continue to help people get to information.
Yeah, for people who at one time had an address and no longer in that situation, you know that we're destroying. What follow-up action do you take to try to make?
Yeah, so we have launched a pretty wide campaign across all of our CCOs to help talk to the clinics so that they're messaging members when they come in, because often in their EHR, they will have the most updated information. But then to have the person at the front desk say, but have you moved in the last 3 years? And if you've moved in the last 3 years, here's a business card with a phone number on it, or you can call this number and we can update your address so that you can receive mail in that space. It is undoubtedly a flawed single point of approach. That's, yeah, so we're working together.
Expectation is not that Pacific Source solves that problem today, but to acknowledge that there is a problem.
Yeah.
Maybe look at, is there some way we can create something creative to step into that?
We also partnered with Mosaic on a significant redetermination effort. And I don't know if you want to speak to that at all.
Yeah, I think also we worked with LCA and there's a lot of people out there in different settings working to enroll people and capture them where they are, whether it's out on a mobile van, at LCA, in the clinic. So there's a large effort on the ground to try and get as many people connected to these enrollment people that can help them. Thank you. I wasn't aware of that. So. Yeah.
Wonderful. Anything else?
No. Okay. More information.
Yeah,
You
in the
think it's
packet.
packets.
Thank you.
Thank you.
All right, so moving on. So pedal clinic update, and our apologies for running behind. Thank you for joining us. Mike, wonderful to see you. Hello, can you hear us okay?
Yes, can you guys hear me?
The floor is yours.
All right, let me share my screen. Here. Okay, that's the screen. Okay, are you guys seeing that Word document with pedal on the top?
We are.
Okay, so I'm not gonna read it. I'm just gonna kind of speak to it and I'll keep it brief since we're about out of time. Basically the pedal program, we've been meeting with our steering committee monthly. That's made up of members from St. Charles, Mosaic, Copa, Coipa, and Pacific Source. Working on coming up with a long-term, longer or medium-term vision for funding and making the pedal program more sustainable long-term. So out of the first, I'll just give a quick update on the bridge funding there that we received at the beginning of the year. So out of that $1,646,000 has been spent year to date. So at the current rate, we estimate we'll have around 200,000 left, which will get us through potentially first quarter next year, which is actually really good timing. One of the things the steering committee has arrived at is a funding model with some enhanced funding from Pacific Source for the pedal program. We're working with them on the details of how that will work. Right now, we actually have another meeting tomorrow on that subject with Pacific Source. So that model will reduce the investment by St. Charles required to fund to keep the pedal program going significantly. And our goal is to get the program so that we can at least go a couple of years with the program substantially funded until such time that we as a community are ready for some type of a value-based funding model. And that would have to be a community partnership since St. Charles doesn't have a presence in the pediatric service in the community, but yet we have the pedal program. So it would have to be really a community value-based funding model in the future. That's the ultimate goal. But this medium-term bridging solution with Pacific Source should give us the runway to get there, which is great. Some of the other things the committee has been working on is just improvements and collaboration between pediatricians in the community and pediatric groups and the pedal program. How can we work together to have trained pediatricians to provide some care for lower acuity patients, so the pedal program can focus on more of the higher acuity patients since they have a large backlog. We also have a lot of improvement projects going on internally within the program to reduce some of the burden, administrative burden with these patients. There's a lot of gathering of resources from all over wherever these patients have been seen. That takes quite some time. So we're working on a lot of that process improvement so that we can just increase the throughput of the pedal clinic to, again, try to work down that backlog to serve the patients in the community. So overall, I think things are going well. We're headed in the right direction. And I guess because of our shortage of time, maybe I'll just pause for questions.
Yeah, looking around the room. And online, do you have any questions? So anything keeping you up at night right now?
No, I'm optimistic with the direction we're going.
Okay, good answer. Anything else? It looks like we don't have any questions. That was great.
All right, thank you.
Yes, nice to see you.
You too.
Okay, Governor?
Yes, we did not meet this month. Vacations over the next couple of months. It's a little difficult to get people in the room at the same time. We have two major tasks that we're working on. One is serving as a nominations committee. We received nominations from suggestions, recommendations from the board, and we are pursuing each individual on that list to make sure that they are willing to serve. And we should have that information at or before the next board meeting. And then the second thing we're working on, we've solicited from the board and others a list of topics for a deep dive, some of the more challenging topics that we haven't had. And the governance committee will be taking a look at that, making sure there are not any additional to add that maybe have come up since we solicited the list, and then prioritizing and making a recommendation back to the board at the next meeting on which topics, what order.
all in the development of a work plan.
Yes.
Wonderful. Awesome. Any questions or comments? Okay. Right. Is there anything else to come before the council? Don't see anything? We just give it, oh, yes, please. Yes, thank you, Heather. Some late night reading. And I would just end with, for the month sort of that many people think of gratitude. And want to just offer my gratitude to everyone that is part of this effort. It is clunky, it is slow at times, sometimes it moves too fast and then, but it's, if anything, it is our journey. And I couldn't be more grateful to be on it with this team. It's the reflection of the work that was just done in each of the communities, and the one that will be happening tonight in Madras. I think is a reflection of the dedication and passion of the Health Council team. And just wanted to say that I'm just proud to live in this community and that this is how we do things, and that we get to be on this journey together. So I hope everyone stays safe and enjoys your time and you get a little time off. And we will see you in December. We are adjourned.